Good evening, everyone. And thank you, Charlene, and thank you so much to CMSNE for inviting our participation this evening. We certainly appreciate the longstanding relationship with CMSNE and many of your members. Hebrew Senior Life is a 100-plus-year-old not-for-profit organization and the only senior organization that is affiliated with Harvard Medical School. We are an integrated system of healthcare, senior living, research, and teaching, and we serve more than 3,000 seniors on a daily basis. Hebrew Senior Life grounds itself in a set of cultural beliefs, and one of those cultural beliefs is what matters most. We believe that asking questions to understand what matters most to our diverse community of patients, residents, families, and employees helps us achieve our goal of delivering holistic, patient-centered care. By asking what matters most, we have also gained expertise and comfort with guiding advanced illness conversations. One of our service lines in our home and community-based services is palliative care. We offer both inpatient and community-based palliative care. We serve homebound seniors under our home health care umbrella with palliative care, and we also offer palliative care as a specialty program at our Hebrew Senior Life Rehabilitation Center in Boston and Hebrew Rehabilitation Center Newbridge in Dedham, where both our short-term patients and our longer-term patients receive services. During COVID-19, our palliative care team partnered with our Hinda and Arthur Marcus Institute for Aging Research to offer a thoughtful, wide-reaching, and efficient response plan to address the advanced illness goals of our long-term care patients in partnership with their healthcare proxies. We leverage telehealth to do this, and I look forward to being able to share further detail about this with you this evening. We conducted this program as a research study so that we'd be able to understand the impact of our work moving forward and perhaps in a post-COVID world. Hebrew Senior Life is an Honoring Choices partner, and our Director of Palliative Care Services, Nurse Practitioner Emily Palmer, is the Metro West and Greater Boston Regional Community Champion. I feel honored tonight to be sharing this forum with Ellen DiPaola, President and CEO of Honoring Choices of Massachusetts. Ellen and I will be presenting to you an overview of HSL's project, Advanced Care Planning with Telehealth for our long-term care patients. We'll talk about the challenges to overcome and the impact of a collaborative approach in this sort of work. We'll also propose applications for integration of advanced care planning using telehealth into your case management practice, and we'll demonstrate how to access the new Massachusetts E-MOLST portal. Thank you very much, and I look forward to offering you more details.
Thank you, Maureen. We look forward to hearing your presentation soon. So I'm going to give you a brief bio of both Maureen and then introduce Ellen and tell you a little bit more about her. But I'd like to keep it short because they've got so many wonderful things to say, and you've got their bios in your packet. But suffice it to say, so Maureen Bannan has been at Hebrew Senior Life since 2015, and prior to that, she had been the executive director of the Walpole area VNA, as well as a vice president of clinical operations for Stewart Home Healthcare. So she is really an expert in the field and an innovator in trying to address the needs of people at Hebrew Senior Life and the people who they serve. And I'd also like to next introduce Ellen DiPaola. So Ellen is the president and the CEO for Honoring Choices. Again, an innovator in really transforming the care of older adults, as well as impacting the lives of people of any age. She has expertise in guardianship and conservatorship in her work as an attorney and really focused on healthcare planning. She is an appointed member of the Department of Public Health, Palliative Care and Quality of Life. This is along with an interdisciplinary advisory committee, which Ellen's expertise and her ability to be on that committee really has moved things forward. So without more further comments, I'd like to introduce you to Ellen and back to Maureen and to start our presentation for the evening. Thank you.
Great, thank you, Charlene. Thank you for that lovely introduction, and I want to also thank Maureen for inviting me to be part of this event tonight. We're always honored to support their work. When I first heard of this project, I was so excited that the work that they did. We publicized it throughout Massachusetts and New England, actually, and I think you're going to love hearing about it tonight. And many of you might know me. I was on this series just a few weeks ago, and the work we did was around offering you a webinar on seamless planning conversations from simple to serious illness, and I see that's still available. So all of the tools are still on the Honoring Choices website, and I'm happy to answer any questions tonight. And I'll just turn it right over to Maureen.
Thank you, Ellen. So thank you again, everyone, for the opportunity to share what we think was a very important project over at Hebrew SeniorLife, and we know it has broader implications. So, I'll move right into our work here. As was the case for every citizen of the world, starting in February of 2020, our lives changed, and certainly Hebrew SeniorLife was no exception to that. We realized our first case of COVID-19 on March 31st. However, we had certainly begun planning in advance of that, knowing it was just a matter of time for us. Our planning began in late February, and we had the good fortune of, as I said earlier, of having a palliative consult service, and knew that they would be an important part of our work moving forward. So I mentioned earlier our Marcus Institute for Aging Research, and I thought it was worthwhile to share that they are actually located on the same campus as one of our long-term care facilities. Marcus Institute is located in Boston and shares the campus with our Hebrew Rehabilitation Center of Boston, where we have 405 long-term care beds. We have an additional 220 long-term care beds at our HRC location in Dedham. So you can see we have a significant number of seniors in that particular service area. So we all recall how rapidly things were moving. I know that in the course of a week, I sometimes may say, well, what day is it this week? Because the week is flying by so fast. I can vividly remember during those days, many of us looking at one another and trying to remember what time of day it was, because things were moving and changing so rapidly. So we knew we needed to move forward with planning our objectives quickly. We knew we needed to understand who was in the most need for advanced care planning. We needed to understand with that who had COVID-19, didn't have COVID-19, what were people's cognitive status, what were their healthcare proxy statuses, and if people had activated healthcare proxies, who were those decision makers. And of course, we wanted to be compassionate and thoughtful in thinking about approaching these conversations. We certainly understood that we needed to document this and then make sure that the healthcare team understood what our seniors' preferences were. And we wanted to be able to track our efforts because, again, we wanted to understand, is this impactful for future, meaning 6 months down the road, or even a time that was post-COVID. What I'm sharing with you here is really our timeline for our work effort. Again, you can see on March 31st, our first case came. And again, we began immediately planning and really approached this in a SWAT mentality to create that sense of urgency. So we referred to the team as our ACP SWAT team. And on April 12th, we really did intensified education for people on tools that we had put together. We had a discussion guide. We were leveraging the talents of redeployed staff, workflow, our EMR. We were prioritizing risk and immediately moved into the work on April 13th. Our last patient was on May 21st, and then we finished the study work on May 26th. It's important to share that because we wanted to conduct this as a study and really, again, be able to prove the impact, we knew we had to put some date parameters around this. So we set April 13th as the last date that somebody could, quote, register to be in the study who did not have an activated do not hospitalization status. So that's important to note as we go on in our study. So I mentioned that we needed to leverage our electronic medical record. We happen to use Meditech. And for those of you who might be familiar with Meditech, this will likely look familiar to you. This is the resuscitation data. And, you know, we recognized actually going into this work and anecdotally that we did have an opportunity to do this better when we were having people move into our long-term care residence. We felt like we were really strong with our capture of our DNR statuses as well as DNI, but do not hospitalize was something that we quickly realized in the context of this work that we could do a better job with. But again, we realized that anecdotally, and you can see there that that is one of the choices, transfer to hospital, yes or no. And you can see some of the other informative data that's in the EMR as well. Then we began designing the team, and we broke it down into two teams. We had our palliative care clinical team that was already deployed on our long-term care as well as our short-term rehab units. And this consisted of nurse practitioners, as well as physicians, social workers, and the lift, as we estimated it, that would be required of those 5 people altogether was approximately 5 to 10 hours a week. And we asked them to focus on residents who had decision-making capacity. We then took this group of redeployed individuals, there were 5 of them, and recognized that we had about 30 to 40 hours per week of work for them, again, as a whole, all 5 of them. And the reason for that was because we wanted to focus on our residents who did not have decision-making capacity and therefore had activated healthcare proxies. Those were people we were having great urgency about. And as it turns out, that was actually about 75% of our long-term care population that had activated healthcare proxies. Then we moved into creating a decision guide, and the one we created was a compilation of efforts that came from CAPC. For those of you who may not be familiar, that's the Center for Advanced Palliative Care. That's a national organization. We also referenced work done by Vital Talk, as well as Respecting Choices, and then Ariande Labs. And then we recognized that we needed to have a protocolized workflow for these people. And there were 2 reasons for that. Again, this is a study, but also, you know, I've been reflecting back on this myself a bit recently. Again, it was such a time of all of us being worried about our families, our loved one, our kids, our parents. It helps the team to have significant directive for them to be able to move through this process. And then we knew we were going to need to do rapid training. We were going to need to train staff in the ACP discussion, advanced care planning discussion, and then the necessary workflow to move through this, make sure we were hitting all bases. And then I'll talk a little bit more about what REDCap is. It's basically a piece of software that I refer to as a scrubber or a filter that helped us create sort of blind data so that patients' names were scrubbed away, but also helped us filter the data in a way that helped us recognize if we were having an impact or not on what we were trying to do. So I know this slide.
Maureen, could I just interject for a second? If you
Absolutely.
could explain some of the acronyms, especially DNAR, please.
Sure, that's a,
Thank you.
It's basically, yeah. Thank you, Charlene, for that question. DNAR is the same as DNR, which is do not resuscitate. And then DNI is do not intubate. And DNH is do not hospitalize.
Thank you.
Yeah. Thank you, Charlene and team, for that question. I appreciate it. So again, I know this slide looks a little bit busy, but it helps really for those of us that are visually based, define the workflow or the infrastructure created by our Marcus Institute to make this happen. And the slide reads right to left. So on the right side, you'll see clinical teams and the computers there. That was the group of people that were responsible for going into our electronic medical record, EMR, which for us is Meditech, and they were the ones capturing that resuscitation data about the patient, whether or not they wanted to be hospitalized, was that activated, meaning was there just a no there and did they want it to still be a no, or was there a yes there? And did people have activated healthcare proxies, meaning an identified healthcare proxy, and for one reason or another, that person was the spokesperson for this patient. In our setting, that generally means somebody has cognitive impairment. That data was then entered into what you see there labeled as COVID ACP Data Mart. And again, this is all Marcus Institute research lingo. But that basically, again, was another piece of software that more finely filtered the Meditech data and then pushed out an email to the palliative field teams. And these palliative field teams were the ones who were being deployed to have these conversations. In our situation, we're focusing this evening on the study, which is with healthcare proxy identified individuals. Once that team finished their work and completed their workflow, part of that workflow was that their data was dumped back into REDCap, where basically the patients were de-identified, so we could, in a more easily obtainable way, just look at the data that we were capturing. And again, we wanted to make sure we were having an impact on the service offering we were providing. I recognize this slide may be a little bit difficult to read, so I'll offer you some highlights. It's our discussion guide that we had created. And a couple of takeaways from this. You'll see the first section is a prepare section, and it's really offering 3 bullets to the field team on how to enter into these conversations. Remember to look at the patient's record. What's their current code status? What are their most recent notes that might inform that code status? Who is the patient's healthcare proxy? And then the last sentence there isn't bulleted, but it's a really important one. Again, remember to take a deep breath. Things were moving really quickly. We were all worried about our patients, our fellow employees, and our own families. So I thought that that was really important. And then you'll see that there's more of a prescribed check-in as well as ask about COVID section. And the reason for this, again, is because we wanted to enter into each conversation in a similar way. We knew the data that we would capture under the layout issues would likely be very different because every person and their healthcare proxy is unique, but it was important, again, to measure our impact, that we gave everybody the same opportunity to answer the questions that we found were most important to be taking best care of our residents. And then we captured this information in this sheet here. And what I'll highlight here is you can see that there are pieces of information that say contact is complete, no further action. But then there are instances where follow-up is needed. And I would say those were instances where the healthcare proxy likely wanted to talk to other family members or think this over because, again, thinking back to a time where we had so much less information than we have now, this was really asking a lot of a healthcare proxy because, again, things were moving rapidly and the disease was spreading within our sites more quickly. And so the healthcare proxy was, of course, scared for their parent, but also recognizing that hospitals themselves were having their own challenges too. So we really wanted to give people that space. And this document allowed us to make sure we circled back to people. And this really reflects the workflow that we did on a daily basis. We reviewed that daily list, the email. We, when it says cohort by unit, what that means is we looked at the patient's healthcare proxies we needed to reach out to by our individual units at our two long-term care locations. And the reason for that was really an effort to make our own work as efficient as possible and to let the teams on those units get to know the field teams that were doing this work in case they had any questions of them. And then this also allowed us to disperse, triage the calls appropriately to each member of the team. Then we reached out to the healthcare proxy and utilizing the decision guide, the field team did their work. They had their advanced care planning discussion, and then they went back in, documented that discussion in Meditech, our electronic medical record, EMR, and then that's where that REDCap software was able to pull some of that out and filter out the important pieces of information. And then so important, and this could even be at the top, was making sure that this field staff having these conversations communicated this with the primary care teams. On our long-term care units at Hebrew Senior Life, there are nurse practitioners. They interface with our Hebrew Senior Life physicians. We hire physicians at Hebrew Senior Life that are part of primary care teams we create for our long-term care patients. So it was really important to communicate with them in an email, as well as what we call a soft handoff as well, when appropriate. In morning huddles, that meaning face-to-face communication whenever possible, really making sure we captured every mode of communication we did to make sure that everybody was on the same page with the patient's wishes. So this is a case study that I feel confident we have time to share. This is a patient that's very typical of a resident at Hebrew Senior Life, although no joking aside, he's a little bit on the younger side. The average age of our patients is more around 90 to 91, and it's not unusual for us to have people in their late 90s and early 100s. But what is very, very typical for this gentleman is that he has what we call multiple comorbidities or many illnesses that he and his team are trying to manage. He moved into our long-term care facility in 2018, and he did have an activated healthcare proxy. That was his daughter. And they already had acknowledged or activated that they wanted Mr. Smith to be a DNR, do not resuscitate, meaning no CPR, no chest compression, and a DNI, meaning do not intubate, don't put me on a respirator, don't want any of that. You can see he's a very engaged member of our community. He interfaces with our chaplains and enjoys some of our events, and he's a retired barber. So an RN, which reflects the multidisciplinary nature of our field team, he was able to reach out to the healthcare proxy on April 20th and began having the advanced care conversation. And the daughter was able to say that indeed she wanted dad to become a DNH, do not hospitalize. That order was entered into our electronic medical record, and we were so thankful for that because within 8 days, Mr. Smith became positive for COVID. Thankfully, if at his age, you could call it a mild course, he demonstrated lethargy and a dry cough, not as ill as many others, but still impactful for him and his family, certainly. I'm thrilled to report that Mr. Smith fully recovered. He continues to live at our long-term care facility, and he's now been fully vaccinated. And as we're slowly reopening to visitation, which we are, he's begun enjoying visits with his children again, which is wonderful. And the daughter has decided, the healthcare proxy, that the DNH, the do not hospitalize status will remain in place along with the DNR and the DNI. So these next two slides are going to be about data that we gathered between April 13th and May 26th. That yellow or gold bar at the top, that reflects our long-term care residents who did not have a do not hospitalized order. And that was a total of 54% of our long-term care residents who did not have the do not H order activated, a DNH order inactivated. Of that 54%, on April 13th, 80% of those people, we didn't know their COVID status. 12% we knew for sure were COVID negative because something caused them to have had a COVID test. 8% on April 13th were COVID positive. By May 26th, we were able to transition of the 54% who had been do not hospitalized, 39% of those people activated their do not hospitalize wishes. And on May 26th, we still had 69% of those people as COVID negative and 29% were COVID positive. So for those of us that might be a little more text-based, this is saying, offering very similar data with a little bit more depth. Of those people who who had started do not hospitalized, 52% of those ended up being diagnosed with COVID-19. And unfortunately, 10% of those study participants passed away. Of those 10% that passed away, 81% of those were COVID positive at the time of their death. And then you'll see that of those people that passed away, 72% of those people had a do not hospitalize order in place, and therefore 0% of them were do not hospitalized. So really the takeaway from this slide is that you can see the positive impact of the study. You can see the positive impact of the study because we were able to capture many more do not hospitalize orders. For those of you who like data and want a little bit more of a deep dive, we did do a write-up in the American Journal of the Geriatric Society, And I'm thrilled to share that our nurse practitioner, Emily Palmer, as well as our physician, Susan Mitchell, in the Marcus Institute were co-leads on this. And that is available to people, again, if you want to look at that in a little more detail. And then earlier I had mentioned CAPC, which again is the Center for Advanced Palliative Care nationally. And annually, they request poster presentations for unique programs that have been conducted over the course of the year. And they only chose 8 this year, and one of them was this program. So for any of you who might be members of CAPC, you can get on the site and plug in Emily Palmer's name, and the project will come up. It's pretty neat to look at, and it offers just a quick snapshot. In terms of lessons learned and future direction, you know, it was really super interesting to be able to, and powerful and impactful to be able to use telehealth in the SNF setting. Overseeing home and community-based services, we've long used telehealth in that setting, but really the model here suggested a capability to use it in the SNF setting with long-term care residents. And what was interesting is we used it in a variety of ways. We used it in Zoom, on iPad type devices that we were able to leverage that we normally use with our expressive arts therapy teams for music type therapy with our patients. We instead were able to make these Zoom capable. So we were able to do it with video capability with our healthcare proxies, but also sometimes we just used the phone, which worked just as well. And we were also just awarded a grant that will be allowing us to use some Amazon Echo technology too. So more about that in another time. But all of this was possible for us to use Zoom and FaceTime because the Center for Medicare and Medicare Services had put waivers in place to allow that sort of thing. Those use of FaceTime and Zoom were not allowed for HIPAA-related type conversations prior to COVID. I'll also share in terms of the interdisciplinary reach of the program. You know, I will say that I mentioned earlier, Hebrew SeniorLife grounds all its work in its cultural beliefs. And I think because we do that and that several of those beliefs relate to succeed together and teaming up and ask what matters, we really were able to navigate an environment that was very trustful because of those things. And everybody really was able to team up quickly, knowing the urgency that was before us. Of course, we had room for improvement. I mentioned that earlier, that we recognized we could do a better job with our long-term residents on move-in with capturing do not hospitalization status. And I already see that work being done as we move forward now. So Charlene, I'll stop there. I know I'd welcome Ellen talking about the Mass E-MOLST, but if there are questions that you want me to answer now or wait till later, I'm happy to do either.
Yes, I really think one of the questions that's really pertinent at this point is, what tools did you use to impart empowerment and empathy to your audience as you were doing all this great work?
Yeah, thank you for that. So being video capable as much as possible was really significant for us. It was our first go-to so that we could be having face-to-face conversations and really be having eye contact. And, you know, we all know the usual, the head nodding, the expressions on our faces to be able to make sure that we were conveying to the healthcare proxy how difficult we knew that this was. Our other choices when we did, for example, phone calls, that was really driven generally by the healthcare proxy. Again, we used FaceTime whenever possible as well.
That was excellent. Thank you. And we look forward to Ellen joining you now and continuing this conversation.
Thank you. And before we leave, I wonder if we could just go back to that slide. I think part of what I'd like to start with is just echoing how important these results are. You know, I was so excited about this because in the most crisis-oriented moment, Hebrew SeniorLife did this wonderful study just when we needed it, just when people were thinking, how do we have proactive conversations with our high-risk patients? You know, it was almost an impossible thought given what was going on at the time. So I just want to echo here that what we saw on the honoring choices side absolutely supports this work and this study. We saw how powerful telehealth was that was the first question for us in March was, how do we get to our high-risk patients and talk to them about their wishes for care? So as just the power of telehealth was amazing there. And what we also learned is that we needed to lift some of the barriers that were already in place, and we hope to think about that in the future. One of the barriers was we could talk to our healthcare agents, but if we wanted to have a MOLST conversation, meaning that we wanted to write down what people wanted for do not resuscitate, for ventilation, for transferring to MOLST hospitals, that's in the MOLST form, right? The medical orders for life-sustaining treatment form. The problem with MOLST is you have to be in person in order to give your consent and for the clinicians to fill it out. So one of the things Honoring Choices did right away is we wrote the state and we said, you've got to give all these clinicians a waiver to be able to use telehealth to do verbal consent on these things over the phone. So we were so happy that the state, given all that they were doing, they put that waiver in place. Unfortunately, it just got lifted with the end of the pandemic soon to come and the state of emergency being lifted. But we hope to put verbal consent back in to support telehealth and to support the projects that Hebrew SeniorLife did. I just also want to mention too that that one of the findings too was that you found that Maureen, if I have this right, that your RNs and your other frontline staff were incredibly instrumental in having conversations. Is that right?
Correct. Yeah, we did. I had mentioned that we leveraged the talents of our redeployed staff because there were some portions of the business where RNs weren't needed in their particular location. And so we redeployed them across the organization, and onto this team was one of the places we did that. And yeah, you're correct. Someone came out of retirement to help us, the former director of the palliative care program, and she's actually a psychologist and a chaplain by background. So very diverse group of people, and it is teachable.
Yeah, and that I think is what we saw too. What we saw is who was having conversations? Care managers and RNs and social workers. And, they were having more conversations than sometimes our physicians and our nurse practitioners. So giving these tools to you directly is, I think, is proven to be very effective, certainly by that study, and we found that too. And the last thing we found was consumers. Consumers were saying, I want to get, if I haven't done my healthcare proxy, now is the time. I need to do that. Or if I have a serious illness or I'm really worried about COVID, I want to get to my clinicians to talk about how do I write down my wishes for care. So we saw a tremendous increase in the downloads of our healthcare proxies. We also, the wonderful thing is we saw it across the board in the 10 languages of the healthcare proxy that we offer. And that was really encouraging to us because we've been working with trying to have clinically cultural conversations and with these translated documents. So all of that stuff is still on the Honoring Choices website, and that's the best of what we do at Honoring Choices. We support our partners like Hebrew SeniorLife to say, look at this great work, and also you can use the tools to replicate this and make this happen. So I just wanted to mention that, and congratulations on that wonderful study. I am just in awe how you pulled that together at the height of COVID and had such, wonderful results with it.
Thanks, Ellen. I think it also really speaks to the ability to combine clinical with research in such a meaningful way, but in a way, in a setting that was an urgent setting. Often we hear these things are more done in more of a sterile environment, I think. And boy, this was fast moving and right in the heart and the center of the clinical environment. So that was exciting for us as well.
It's great. It's great to learn all these things we hope for and wish for are really possible with planning and delivering good care. So I wanted to just take this a step further. One of the things that happened from COVID this year is in the midst of all this, again, trying to work with people who we couldn't get to. There was a physical distancing happening. Everybody was home. We couldn't come into hospitals. We couldn't even come into our primary care offices. How did we have these conversations and how could we document them? So with a team of people, and I'm going to ask you to look at the right side of this slide, so we'll look at it a little backwards. Look at the right side. That's the Honoring Choices webpage. Everything I'm going to tell you now is just condensed, but it's also in depth on this webpage. And this is the webpage on the MOLST, the E-MOLST, meaning the electronic MOLST web portal. So right about in April, we worked with the Mass Coalition for Serious Illness Care and Ariadne Labs, and we said, how can we help our frontline clinicians have these meaningful conversations and then write down patient choices in the MOLST form. Now, if you're not familiar with MOLST, again, it's medical orders for life-sustaining treatment. It's one of the 5 Massachusetts documents where you can use, if you have a serious illness, with your clinician to have a conversation about prognosis and about treatment options, and to select on the MOLST form what you want for life-sustaining treatments. The 3 big choices there are now mirror Maureen's study as well, which is the first one is CPR. Do you want CPR? Do you not want CPR? Do you want ventilation or not? And do you want it to be non-invasive or not? And the third decision is, do you want to be transferred to a hospital or not? So those right now on our MOLST form are those immediate orders that can be used with clinicians. But as I said, we couldn't, patients couldn't get into doctors' offices or their nurse practitioners' offices to do these forms. So telehealth stepped in here, and we also stood up this E-MOLST web portal. And basically it's still right there, and it's been really useful in helping people's workflow in getting this done. Any clinician who's those 3 signing folks on the MOLST form, the physician, the nurse practitioner, or the physician's assistant, or people on their care teams, as long as you're working with one of the signers, a care manager could actually get access to this web portal as well. You just need one of the signers on your team to open the account, and then those signers would authorize you as part of the team to actually have these MOLST discussions and be able to fill out an E-MOLST form. So that in itself is much more information about that is on the website. But we wanted to tell you that we wanted to make sure the care teams were involved here, not just the 3 valid signers on that form, but the people who actually have conversations. So let's say your clinician that you're working with signs up an account, which is free on the web portal. They just need basic information about who the physician is. They say, here's my care manager and my care team. Here are the names of these people. Great, you're now on the portal. You can open up the portal and you have a choice. Your choice is, if you've already had a serious illness discussion with folks and you feel good about knowing what patient choices are, you can go right to the electronic, I keep saying E, but it's the electronic MOLST form, and start to fill it out. But let's just say you want to have a conversation with someone. The beauty of the web portal is that you can decide instead to go to the Ariadne Labs Serious Illness Conversation Guide, which is built right into the portal, and it will lead you step by step through a series of 7 or 8 questions to help talk about the prognosis, where people are in their serious illness, talk about what they're worried about, what they'd like for care, and really get at some of the worries and the wishes for what would happen if they were facing COVID, for instance, or a life-threatening illness. What kind of choices, what would they decide for life-sustaining treatments? So it takes you through that step by step. You don't even have to have pre-training on that. And that's what's great about it. It's on the web portal. And then at the end of those questions, you will have, kind of a printout yourself of what patient wishes are. What did they want? And then you would transfer them to the E-MOLST form. So you'd then click on the E-MOLST form and you'd go through it one more time with the patient saying, this is what we talked about. Is this correct? Is this what you select for life-sustaining treatments? You check it out with them. And at the end of the E-MOLST, you select the treatments. The next section is we need 2 signatures. We need the signature of the patient or their healthcare agent, and we need the signature of the clinician. Now again, how are we going to do this on telehealth when the state really hasn't authorized e-signatures for us yet? Another thing we need to work on. But what the state did was they allowed us through this web portal to do electronic digital signatures. So all your patient needs to have is, and actually, if you're a care manager now, you would actually stop right at this process of the signing. You can actually do everything right up until the signing and then turn it back over to your clinician who has the authority to sign. But all your patient needs to have is an email address or a smartphone. And then there's a couple of steps. We bring people right through each one. It's pretty simple. And the patient actually, or the agent takes their finger and say it's on their phone and just signs their name. And it will appear, it will populate right on the web portal in the right place on the form, on the E-MOLST form. And then the clinician does the same thing. And there you go. Now you have a valid E-MOLST form that's sitting right there. And what you would then do is download it for yourself and also send a copy to the patient. So the full explanation of this, there's a video that will really send you through each one of the steps on the web portal if you're interested in doing it, if your team is interested in doing it. We have about 150 to 200 now different organizations using it, and they put it into their workflow, and they seem to really like it for certain, it works really well with telehealth. So we want to let you know it's there. On the left side of this slide, you'll see that we have a lot of resources. There's just the fact sheet, there's a slide deck and a video to bring you through this. We have several videos on, excuse me, if you're a clinician completing the form, how to do it. And the serious illness conversation guides are available to you there. If you don't know about them, I urge you to go take a look at them. They're really simple. And if you are in a position where you're having a serious illness conversation, it's a great do-it-yourself guide to have, add to your own script. We also encourage on the portal to help make sure people have healthcare proxies. So we're able to help people do that as well. I'll just stop. Everything, as I say, is on this web page. Are there any, before I go to the next part, are there any questions about the web portal?
Yes, there's a question. How do you access the web portal for MOLST?
Yeah, so those instructions are right on the web page, the Honoring Choices web page. It's a simple little, we give you a link to where to sign up. The company that helped us was a company called Vinca. And so it's a link to Vinca, and you just say, I'm a physician, I'm a nurse practitioner or a physician's assistant, and this is what I want to do. And they'll send you back a little form, you fill it out, and you're on the web portal.
Okay, great. Thank you. We have another question too that came in. Is there a cost associated with setting up these telehealth initiatives that you've been working on?
Yeah, so at the time, no, because we were leveraging what we had for resources within the organization. So in the time frame we're describing the study, I think I mentioned we were using members of the palliative care team. We used these iPads that we had been using with our expressive therapy team for things like music therapy. We were able to convert those. But if we were to institute something like this, given the size of our long-term care facility, I would see it needing to be a full-time person. And then the cost for the technology, honestly, would be minimal. The cost of iPads have come down so much now, and the video and data, that really it would be minimal. And, you know, you need to remember, you don't have people moving in every day of the week. And so I would imagine that it would be somebody who could be in a role that they would have dual responsibilities. They might, for example, work in the telehealth division in, let's say, home and community-based services, and do some data acquisition work there with that type of telehealth, and do this type of work as well. So it's a role that could be shared across departments too, which is also something that's very reasonable about it. You know, many departments could contribute to the coverage.
Sure. Ellen, how about you from the MOLST web portal perspective?
So sorry. Unmute. I'm now unmuted. So there's no cost to the joining the E-MOLST web portal. We wanted to make it free for everybody. It's being supported by the 3 organizations that I spoke about: the Mass Coalition for Serious Illness Care Area, and the Labs and Honoring Choices. And again, if you go to the Honoring Choices website, and if you go under the resources page on the navigation bar, it's a little tiny there, but I think you can see it. You'll see at the very bottom of the resources, it'll say under planning tools, E-MOLST. And that's where you can just, you know, that will tell you everything. I encourage you to just listen to the 5-minute video, because I think that'll tell you everything you need to know.
Great, thank you. So we have another question that came in, I think that's quite interesting. So assuming that one of the benefits of the E-MOLST portal is portability, how would a person be able to access the portal if they've moved, say, to another state? Are the laws similar in each of the 50 states? Are they different? And what steps would be needed to access the portal if you're in another state, or if you've gone on an overseas trip?
Yeah, it's a great question. It's kind of multi-layered, so I'll just take it apart. So if you are a practicing clinician and a physician, and your person is traveling overseas or in another state, the clinician can still access the form and be able to maybe phone into wherever the person is, domestically or foreign, to be able to offer those instructions about what a patient wants for care. However, we do have, there are 50 different state laws. There are many different MOLST forms, not quite 50, but something like 47 MOLST or POLST forms. They don't particularly, there isn't particularly reciprocity on those documents right now. So they're not automatically honored. Even I was talking to a patient today whose mother lives in Massachusetts, went to New Hampshire for her first vacation in a year, and unfortunately fell quite ill, and they wouldn't honor her MOLST form, her Massachusetts MOLST form in New Hampshire. This was northern New Hampshire, and that's typical. So when typically the forms won't be honored out of state, or certainly in foreign countries. This is this is not something that other countries have. But I do want to tell you about the next piece of news that's a little brighter, if we're ready to do that. So great news about future directions here. After many years of working on this, our state government is taking steps to go from our MOLST program to a much broader, much more comprehensive POLST program. So let me just tell you what that means. MOLST, again, is Medical Orders for Life-Sustaining Treatment. There is an organization, great to look up if you want to know more about this, called National POLST, POLST. It originally stood for Physician's Orders for Life-Sustaining Treatment, but now, through a lot of wonderful study, it's just going to mean portable medical orders. Just make it simple. That's what POLST is going to mean. And the reason I'm excited about moving to POLST is it will give us the things we don't have right now with our MOLST program. So for instance, as we transition to this program, and I want to caution by saying it's going to take a year or so. So nothing's going to happen right away. But the important thing is we're underway with a process, and that process is going to include engagement of community frontline workers. It is going to include engagement of care managers to say, what do you want in a new program? What's not working with MOLST? And how do we take this new program and operationalize it so that we have that first bullet, better clinician, patient, or legal advocate conversations, and we put them right at the center of this program. So it's not so much about the form, it's about the conversation. It goes back to Maureen's work about that idea of putting the time and the energy into understanding where patients are at every phase of life. So instead of waiting till people are at the very end of life, but to be able to say, hey, I just got diagnosed with, the example is, I just got diagnosed with a congestive heart failure. And my doctor says, look, you probably have 3 to 5 years there. So at that very moment that I get that diagnosis, I'm in a serious illness phase of health. And I actually can take my form, whether now it's a MOLST or a POLST form, and say, let's talk about my prognosis. What are my treatment options right now? What are my goals of care? And to have that conversation at the very start of my serious illness, and then right through the process of continuously planning, you know, the patient needs are going to change, my goals of care are going to change, my choices will likely change. And to be able to set that down in our goals of care conversations, but when and if I lose capacity, I want to make sure that is written down in the new POLST form. So the new POLST form actually goes a long way in talking about, in a much better way, what my treatment options are. They're actually on the form. And so instead of talking about just those 3 things about, do you want CPR, ventilation, transfer to a hospital, the choices are going to change now to, let's talk about what full treatments are. Would you like a full treatment? And here's what's involved in full treatment. Here's what we can offer you for care during this time period, so that everybody, including care managers, will have a lot of training on that. So you'll know what to be able to, you know, how to enhance your conversations about that. And as I progress in my own personal, you know, journey, might become a time where I don't really want to choose CPR anymore. I don't want it, but I want selective treatments. And so the next category on the new POLST form has a list of what selective treatments are. And again, it's a much fuller conversation about care and what we can offer people, and where my limits are, what I want and what I don't want. And then as my illness progresses, the third category of treatment is comfort care treatment. So it's very likely I personally will go from talking about full treatment to selective treatments to comfort care treatments. So we are tracking people's history of decisions. We're having really very in-depth conversations. What we hope is that that the new POLST program will include, for the very first time, online training for professionals, consumer education, care provider education, and also a quality assurance component, so we know what people are doing. Are they getting good conversations? Are they getting the care they want that align with those conversations? Are those conversations being offered to everybody equally, so we can track more equality measures as well? And along with all of this is going to come a new statewide registry, which is a big, lovely thing, so that let's say EMS or your ICU people or your ED people want to be able to access your form, they can't talk to you because you're not able to speak to them, they can go to a statewide registry and be able to pull down your POLST form. And so they'll know what your wishes are. So all of that is coming. It's a big undertaking, and we're just at the beginning of it. Honoring Choices is part of the state endeavor to move this forward. And so if you have thoughts and ideas, let me know. But you'll be seeing much more information on this new program through the Mass Coalition for Serious Illness Care. They are just about to put up a website in the next couple of weeks that starts to introduce this. I will make sure everybody has that information as we go forward. Maureen Ferguson, I will make sure you have that information and you can distribute it to the group. And then, you know, there'll be a way for you to tell us what you want. Tell us how we make sure we're crediting the work of care managers as we go forward and how you'd like to be involved in this process. Other questions just generally about it?
Can you talk a little bit, this is a great news. Thank you so much for sharing. Can you talk a little bit about some of the cultural competency initiatives that you've thought about as you've been putting this together?
Well, certainly health equity is a very big piece of this, and as at the foundation of the new program. Any new program should have that at the foundation, and we're certainly going to make sure the care planning documents are translated. The MOLST form right now is actually translated into 10 languages. You have to get it off of MOLST website, but the POLST form will be eventually translated as well. And then we hope to bring in, what we do at Honoring Choices is we partner with people who can typically can have bilingual conversations so that they can speak in a specific language that's comfortable to their patient and be able to translate those persons' wishes onto English documents and into the medical record as well. So we're doing that now, but that's a big journey. We want to make sure we're training more people to have culturally competent conversations so people can understand what their choices are and be able to trust and feel comfortable with making treatment choices.
So one last question I think is pretty interesting. So the pandemic telehealth and Zoom opportunities have had an impact on this outreach program that you probably haven't thought about. So the question is, have you seen an increase in the number of family members that have participated in the program, Maureen, that have gone to do their own future care planning needs?
Yeah, you know, that's such a great question. I can't say that we've tracked that data, but at Hebrew SeniorLife, we actually make it part of our annual testing to see if our, excuse me, our annual competencies to see if our staff are doing that. So we keep an eye on that.
Okay, well,
Allergies, I apologize.
That's okay. Ellen?
Yes.
Are you seeing an increase in the traffic to your website and participation because of the pandemic?
Yes, absolutely. You know, we've been talking about healthcare planning for years, 8 years at Honoring Choices, and we saw such an uptake in, and I say in not only the unique visits to the website, but a download in the forms, and that was really encouraging. And lots of questions from family members, very concerned family members on how to help each other. One of the things I want to mention, I know there are people in your audience from New England as well. And so we get a lot of questions from family members throughout New England about which documents should my family fill out if especially if you live on borders in New England and you live in one place and get care in another. So we've posted the 6 document, the 6 state documents. Every state has its own series of documents, and they're on the Honoring Choices website as well. We also saw a real uptake in that. For anybody who's working in Rhode Island, we just put together with Rhode Island members a care planning toolkit. Again, because we get a lot of calls from Massachusetts people who say, my mother's in Rhode Island, how do I help her do a healthcare plan? So we're working across the 6 states as well.
Well, panelists, thank you both so much for your time tonight. What an insightful, fascinating program of how you were able to really create something long-lasting in a time of stress for a lot of people. So we really appreciate and are very grateful that you're here, and also to Maureen, thank you again for being a sponsor, one of the sponsors of this educational series. We're really very grateful to you for that.